I can tell you that, this is definitely, we put together a community paramedic program down in Wilmington, North Carolina. You guys have seen my background too, New Hanover Regional Medical Center. We're a EMS hospital-based system. I'm going to say no. Either way, you're still going to have to convince your leadership that this is the right thing to do. So for the group, my first question that I want to throw out there is funding. I'm sure everybody in the room is sitting here thinking, well, these are great ideas, but whose candy wishers are paying for them? Because right now, we don't exactly have a reimbursement model lined up as far as insurance companies. We don't exactly have line items written in with CMS. We sure as heck don't have very many states, with the exception of Minnesota right now, that actually pays a fee per service through their state Medicaid office. Bob, you want to take this one and go ahead and talk about that wonderful relationship that two opposing insurance companies had, and how did they come up with this agreement that they were going to fund this program in a competing area for these patients? You guys all got to make sure you pop your lapel mics on.
No. I think I'm on, right? Thank you. With regards to our pilot, the Connect pilot, which I really credit Dan Swayze for bringing this to fruition and working with him, it was somewhat the perfect storm, meaning when I was the chair of Allegheny County EMS Council, and I was able to push it from that regard, but also wearing the hat that I was wearing at the time with Highmark, and Dan with what he was doing with the Center for Emergency Medicine, parentheses, UPMC. So when we put it forth, it was almost how could one do it, not the other? And that's really how it came together. I think the most difficult part of that whole project wasn't the funding, it wasn't hiring people, it wasn't developing protocols and standard. The most challenging part of that was the two entities agreeing on a press release and what was going to be said by whom. So that said, I think with what Dan's going to pull together in a way of data coming out of this project is going to be pretty phenomenal. And speaking of data, I don't want to beat a dead horse, but I think you've heard it from everybody up here today. It's like the movie Jerry Maguire, Show Me the Money. In this regard, show me the data. You can be doing all these anecdotal, wonderful things out there. Patient satisfaction scores off the charts. Just by your gut that you're doing the right thing. But if you don't have the data to back up what you know you're doing, that's best for the patient and best for the system, best for the provider, best for insurance. If you don't have the data to back it up, you're just barking up a tree. And quite frankly, I think that's something that we in-house can and need to do better. But I just don't think that can be understated.
Kathleen, would you echo those comments? How do we get funding for this?
Well, so we were very envious of their funding. And we actually used that as an example of, look what's happening in other parts of the state. Geisinger, as an integrated healthcare system, we have our own insurer. So we said, let's go to its right pocket, left pocket. Let's go to Geisinger Health Plan and see if they would be willing to start. They did offer us a small grant that allowed us to get it going. We were able to demonstrate that the program paid for itself in the claims savings that they experienced. However, healthcare has been on some very rough financial straits for both insurance companies and for the healthcare providers. So that wasn't something that when they went through budget cuts, that wasn't something that they were able to continue because we weren't saving quite enough when they needed to make some other cuts on the plan to continue funding. So we continue to be funded by the beneficence of our CEO at the platform, the hospital that we're operating out of. because he's able to make the financial case that by not having these patients come to the ED, not having them admitted, he is freeing up those beds for higher case mix index patients, so sicker patients that we get paid more for. And so it's soft revenue, it's soft savings, but that belief system is what keeps us going. I've become very proficient at applying for grants. So I'm continually, applying for grants, and I'll get 20,000 here, 40,000 there, 115,000 some other place. We're waiting to hear on some other major federal grants, but we won't know for a few more months.
So, Jack, how much is that equipment going to cost my EMS agency that you want? I hope you can get ESPN on that iStat.
You could.
It looks pretty fancy. So I'm an EMS director, and you approach me and you say you've got this great telemedicine thing that you want to do in the back of the truck, and I say, okay, Jack, I don't have any money. Who's going to pay for that?
Well, I think funding is going to always be the question, but I think the point you make is that I approached you. And this is about partnership, and I think in approaching a CEO or a CFO, you cannot just rely on a phone call, a memo, or an email. There's already enough of that electronic noise out there that these very busy people are going to be able to just discount that attempt to approach them and just move on to their next most important buzz that's coming across their desk. It's going to take, pardon the pun, real FaceTime. To go and get with these people, to build that partnership, to build their trust. That's one of the lessons that we have learned with our program in iTreat, is that it took genuinely going out to these agencies and sitting down with their leadership and selling them on this idea and bringing them to the table and spending time with them and really embracing human capital before you can go out and find the dollars and cents that are really going to come to the table to put the equipment in place.
Okay, there are two doctors. We put the doctors on the end because they're usually the loudest.
To keep us quiet.
Keep them quiet. So I would throw to you, Doc, you said you don't want to go grant funding. You're thinking you want sustainability. So what if I don't have a choice? Would you still be okay with the...
We use grant funding occasionally, but coming from a rural area, grants are great, and then when the grant's gone, people go back to Atlanta. So we wanted to figure out a model that worked. Our bags, we bought 4 bags for Hancock County that cost us about $14,000 a bag. The price of what's in those bags, the price has actually come down since we purchased them. Our doctors can bill for their services. I think that one of the problems is that we have got to put heat in some way on Medicare to pay for in-home care. I understand their concerns about quality and safety, but we don't have hospitals anymore in rural Georgia, and we've got to be able to pay for that. We also need ambulances designated as presentation sites so that they can receive a fee. And we have a good relationship in Georgia with our Department of Community Health that oversees the Medicaid budget. But in all honesty, if you've worked in state government, this group of people doesn't know what this group of people are paying for. So when they realize that they're actually paying $400, the ambulance takes them and they pay money to take them for an unnecessary visit, and then they pay $400 to bring them home, and then you show the administrator of the hospital that they laid in the bed in your emergency room 4 hours waiting for the van to come pick them up. You get traction that way. So that's how we were able to approach each of these companies individually to ask for special consideration, and they were pretty open to that. But I think it's got to be, we did it in a poverty-stricken, underserved community. We've got to change policy nationally by showing the data, by showing that data. So.
Dr. Smith, I'd pose the same question for you that I did Jack. Who's going to pay for that equipment you put in the back of those ambulances? Again, I'm an EMS director and I have zero budget. What do you have to offer me here?
Well, currently, right now, mine is basically off of internal grant funding. And my thing is to first show that it work. And what I have experienced with my institution thus far is that if I can show them that it work, then I have no problem really getting that backing from them and donor support. So there have been now some opportunities for maybe funding from donors in order to move forward with the study. And I think also having them come out and actually do a demonstration, I think that helped a lot with a lot of the administration, is having them come out and actually see what we do, or to actually get on the back of an ambulance and see how the equipment work have really helped significantly for me thus far. But I guess my whole goal right now is just, if I can get this internal grant, no matter how small it is, in order to get the data and show that it works and show that it does have the potential to improve outcomes, that the rest will come. Now, that might be daydreaming, but I do feel that it's the data. If I can show that, then I could definitely move forward.
I would agree that data is what makes the world go round as far as putting money back in coffers. I can say that it was our data on the first grant that we received from the kind folks at Duke that allowed us to get a second award, which was, the first grant for us was $222,000. And grants, by the way, are real easy to do. That was a joke. For those of you who have not, I'm surprised somebody didn't throw something at me from up here on the table. They are tedious, and I would encourage you guys all, if you're interested in putting grants together, locate your government affairs officer within your hospitals. They usually have them. All you have to do is inspire them, and you will be amazed at how much work they will let you do on the grant. They absolutely will help you out, and they'll guide you. But a fully comprehensive readmission grant was then issued from Duke based off the work that we were able to do for almost $1 million. And that allowed us to add a couple of more community paramedics, as well as a pharmacist and managers to work inside the hospital, and just grand, comprehensive type thing. So to the group, I would now ask you, how do you feel about, so we all understand we're in this room basically because of the Affordable Care Act, re-drumming up some ideas that were supposed to be here since, the early 90s? Telemedicine, this isn't brand new. We wanted to bring this about in the early 90s, right? It's just like EMS would be given TPA in the field in the early 90s. I heard that too. Yeah, we forgot about the portable CT scanner there. We kind of need that part. But I would say, is there any concern, panel, about the telemedicine aspects that each one of you bring, and maybe overbilling? Or not? Is this a charge that we are going to bring out into the field that physicians may be racking up charges where they shouldn't be? Again, we'll start with you, Bob. What are your thoughts on that?
I think that's always going to be a challenge. No matter what the technology, no matter what the treatment. If you look back in EMS 35, 40 years ago, and the things that some physicians and others said then, we would never be doing, and we've been doing probably for 33 years. Mm-hmm. I think it's always going to be a challenge with regards to the over usage, overbilling. I had a conversation recently trying to build partnership here, and somebody on the insurance side had said, well, there's always the issue of fraud. Well, yes, there is in every venue. But I would submit that it just takes more policing within and better monitoring that. You had mentioned just a moment ago about getting together with government affairs people within your institutions. I would also suggest this. In my career, I have never, ever seen a time when EMS is at such a crossroads with the potential that I think most of us have always known it has had, and now the opportunities exist to get it more incorporated into everyday healthcare delivery. And I think people are starting to recognize that. But I think too that a lot of these people, to your point, that we need to partner with, they don't know what they don't know. And the CEOs, the CFOs, to Kathy's point, I have heard the same thing at one of our hospitals, the one where we did the telemedicine project along with the community paramedicine. The EMS arrival volume started to drop. Well, that's because we're keeping people in the home. So, you can't have it both ways. But at the end of the day, it's about what's best for the patient. But by the same token, I understand the concern about the CEO and the CFO and the bottom line and so forth. But anyhow, to my point about partnerships and such, we instituted a program at all of our hospitals where the CEOs and senior leadership go out and do ride-alongs with EMS. And I had one person in particular said, yeah, I've known it all. I know those people. I talk to them all the time. I see them in the ED. I said, well, but have you ever done a ride-along? No. I said, well, until you help them carry somebody down from the 3rd floor and you get barfed on when you get down to the landing, you haven't really touched the EMS. So all of our CEOs have done several ride-alongs, and there is not a single one that hasn't come back to me and said, boy, I took a lot for granted. So I think there's great value in that because they will better understand what it is you're trying to sell, and not so much sell, but trying to grow that partnership with the EMS community, with the hospital, the healthcare delivery system. So I think that's something that has been very successful for us. It's been very helpful. It does build those partnerships, and we look at those as partnerships because we look at EMS as being the front line, boots on the ground, first ones to touch those patients that we all share. So,
Dr. Smith, do you think that telehealth will be used at the appropriate time at all times? Is there from your end, is there a way to police the physicians, per se, in internal division, internal affairs for physicians? Do we need that now? Because as an insurance company, I'm going to look at you and say, this is a great idea, but right now, only if you're in a box. That box has got to be here, up on a hill, with this, with that, and in the end, you're going to see you're not going to get it paid for. How are you going to convince Medicare that this is not going to be abused? Because right now, the Affordable Care Act, our job is to try and rein some of that back in.
I don't know if there is a way in order to show that it is not going to be used in a way that it should not be used. I mean, I don't think there's a good way now to show just.
Nope.
So to say that we can do that in the pre-hospital setting with telemedicine when we can't do it now, currently, I would say no. I can't think of a way.
But it's something we probably need to start thinking about right now, right? Before they say, absolutely not, we're not going to pay.
I'm going to disagree.
Okay, let's go.
I'm going to disagree because I think that right now in the practice of medicine, if a physician is corrupt, there are plenty of ways to commit fraud. And if you look at boards of medicine, and I've had a lot of experience doing that, the people, a large segment of people who lose their license are people who came up with a scheme to make money. And so they get in trouble with their board of medicine. The answer to it is stronger ethics training in our professional schools. And one thing we're going to do at Mercer is we're putting in an electronic medical record in our clinical skills course that they have to use, and in our sim lab they have to use, but every student that finishes at Mercer will have telehealth experience. They're going to have to do telehealth visits. They're going to have to understand the ethics of telehealth, the utilization, which is changing every day. I mean, if this glove comes out that you can feel, you think about it, that's going to change what they can do. You have to know right now, as an internist in a rural town, I have to know what I can do and what I shouldn't be doing. I have to know my scope well and what my skills are. The same is going to be true with telehealth, and you have to instill in that student the ability. One of the skills should be what you can do through telehealth. Now, in any entity, you can be crooked. And so telehealth is no different than anything else in that. Plus, if you do community paramedic and community telehealth with paramedics, that's your safeguard. Those guys are the ones that initiate it.
The paramedics sitting right there?
Absolutely. So they need to understand, the same thing. They're going to drive this train. If you're too sick to be seen in the home, they're taken into the ambulance, to the hospital. But if they feel like it's a candidate, it's their decision. The doctor provides the care. But, you know, I guess I'm a little prejudiced in favor of telehealth, but I don't think it's any different than anything else, the same standard of care. And right now, if I wanted to be a crook, I could be a crook.
Right.
That's true. Well, I really, I like your approach of telehealth ethics. I mean, we probably, have you patented that little phrase? Because I think that's probably the first time I've heard
Maybe I
that.
can fund something.
Along with social media and texting, social media ethics and texting ethics, which I think we probably should start teaching in the, in the classrooms. I think that's great. That's a great movement right there, that you actually, if you're going to put these programs together, that you're educated, there's a piece in there somebody addresses for everybody, not just the physicians, telehealth ethics. And I think when an insurance company sees stuff like that, or offices of Medicare or offices of Medicaid, they see that you address that kind of stuff, I think their confidence is going to be a little bit better when it comes to opening their checkbooks.
So you're touching something that's near and dear to my heart as a recovering former insurance fraud investigator.
Ooh, did not see that in the... She doesn't always put that one out there.
Yeah, not my experience on the dark side. I don't talk.
Who's
too
an
much
attorney here too? Raise your hand. Okay.
But our program is a little bit different in that we don't have transport capability. So we're not using an ambulance that a patient is in. We're actually going to be in the home. And part of our structure is, first of all, we are able to record our encounters with the patient, so those would be available if an evil former one of me wanted to see that. But we also have virtual huddles. And so at any point in time, other members of the care team or people that have a HIPAA compliant need to know can virtually eavesdrop in on what's happening. So you have some of those tenets in place. Doesn't make it fraud proof, but it certainly would make it less likely for somebody to want to entertain building a system to try and bilk the system, because others would be able to get into that encounter and be able to see what's going on real time and see those patterns. So that's part of the infrastructure that we've got built into our program.
I like that, and that speaks to quality measurement, isn't it?
Right.
I mean,
We're doing that for quality, but it has that
sure.
other impact, that collateral benefit.
That's awesome. Well, we're getting close to your break. Don't get too excited yet. But I wanna throw this question out to the panel before we get to their last break, and then we give them a chance to ask you some questions. And if they don't have questions, I'm gonna ask you some questions. So, panel, I'm a registered nurse sitting out in the audience right now, and I'm sitting here thinking about how great this stuff is, and I'm sitting here thinking, well, why can't we use RNs for this? Is this just why is it just paramedic? And if I work in a home health care agency, these community paramedics are coming in and they're going to be taking my job? Have you guys have any kind of pushback from the nursing community, which has pretty much been doing this for years as far as home health care in the community? And if so, what did you have to do? Because I'm sure that this is something that was quite a burden for you. Bob, you want to start again? Break tradition?
Sure. Ironically, I had the opportunity and the privilege last Thursday to testify before the Pennsylvania legislature for a hearing on House Bill 1113, which is community paramedicine bill, directed toward reimbursement and so forth. And one of the many groups that testified was the Pennsylvania Nurses Association. And they made some points about making sure there were standards, making sure that people were certified, trained, and so on and so forth. But I didn't get the distinct sense that they were saying, you're crossing the line here. This is our job, that's your job. Although we have heard that in the past. I think one person I know has been very successful in having that conversation is Dan Swayze. But what we have, I think, said collectively is that, yes, that's what you've always done, and yes, you should continue to do that. But we're sometimes talking about a different population here. We're talking about the EMS loyalty team members, or frequent flyers. We're just being more politically correct with the EMS loyalty team nowadays. But that group is very, very well known to EMS. They're very well known to the emergency departments and so forth. And by and large, that population, because of that frequent use, they know and they trust EMS. They already have that relationship, good, bad, or otherwise, but they have that relationship because I can't remember who made the point earlier, it might have been you in your opening remarks, where, you know, with what we've done with the 911 system across the country, I think we're probably our own worst enemies, and we've done it so well. When in doubt, what do? Call 911. Somebody will come, somebody will take care of you. As Dr. Summers said, you know, we'll take you to the hospital. So that EMS, I think, on the front line there has that opportunity to impact these patients in a more positive fashion by keeping them out of the hospital. You know, the Visiting Nurses Association, for the chronics and so forth that they deal with in this population, I think there's a crossroads there, but I think they're distinct enough that there's plenty of patients for everybody to be seen and keeping them in the right space.
Kathy, you agree?
So our pushback came from a different set of nurses. So we didn't have an issue with or pushback from the home health nurses because they know that when they are enrolling a patient, the response is, we can get to you in 4 to 6 hours. We're able to offer an almost immediate response, very nimble resource that's able to get to them quickly. And so for home health nursing, they said, that's great. You can get to them right away so that we can get teed up to see them later to fit in with our schedule. And so that partnership has worked really well. Where we had pushback was from insurance care managers who said, well, maybe we should be the ones following up with that. And so that was not something that we anticipated. And we had to do a lot of work to get back in care management's good graces to make sure that they understood that a key tenet of our program is that it's fostering the relationship between the patient and the care manager who's going to be following them long term. Once they realized that we actually were fulfilling that promise, that dissipated. But that took us almost a year to regain their trust when they realized the patient was saying, oh, but I had this nice paramedic that stopped by and everything is good. What paramedic? You know, when did they stop by? What did they do? We had to get the communication back in line. But the home health agencies in our area love us.
Jack, what would you have to add to that?
I think, you know, what you're seeing is an evolution of culture. We have been traditionally fee-for-service, and within those rules and those laws, you had to perform certain tasks to get paid. With ACA, now we're trying to change that cultural mindset and look more towards quality of care, continuums of care. And I think where EMS kind of fits into that mold is they have been very flexible, innovative service providers, and they went and they adopt new technologies and they make it fit what they're going to do. And within the tenets now, community paramedicine started as a super rural initiative, you know, out west to try to address populations that had no access to care whatsoever. It's being rolled up now as mobile integrated healthcare, and you're using paramedics to go back into the communities they already serve and to take telemedicine and then to tie them together with their primary care physician, the receiving ED, the receiving hospital's EMR. So everybody's sharing the data about this one patient so that you don't have an ED doc who's writing, you know, another 90 Norcos for this guy because he's a loyal EMS customer, you know, and he's shopped, you know, in 4 different county systems. So we get to know these people, and I think, you know, potentially the fee-for-service modeling is a Pandora's box if it gets applied in a community paramedicine model. But if it's done correctly and it's done to address quality of care, community health, and issues, it can be exceptionally successful.
Dr. Sumner, what would you say to the nursing community to put them at ease?
Well, I have a master's in nursing. I went to nursing school before I went to medical school. So I think really when you get into those scope of practice things, it's about money. You know, it's about, you know, so you figure out what the real issue is. They're worried that their job will go away. Home health nursing is a valuable part of of healthcare, they have a specific role. EMTs, as they said, are much more flexible. In Georgia, we had a scope of practice war about nurse practitioners and PAs, and the nurse practitioners claimed that they were the rural health providers and the PAs, you know. So we just, if you took their zip codes where they were practicing, they were all urban. Almost 80% of PAs were working for specialists. So when you really get down to the facts and look at who's providing the care, there are plenty of patients for everybody. And I don't like to hear about scope of practice wars. I think the most important thing is to say, put the patient first, and to let everybody work to the max of their ability, because there's lots of need out there.
Dr. Smith?
I guess as far as from the acute stroke process, the only scope of practice wars that was potential we were concerned about was for, the ED physicians. We didn't want them to think that we were completely taking them out of the picture. So I would say it really have to be a collaboration with them. And the way I approached it was that we have this amazing setup in the back of the ambulance. How about we work together? Because it's not just stroke that we can use this equipment with. It's so many other things, trauma that, but we can take the stroke component off your hands, so that will free you up for other things. And that has been the way that we have kind of worked things out.
Good. A good example that it's not just paramedics and RNs, especially with telehealth. It's going to be physician on physician with the specialties. I really want to commend the stroke work I'm hearing being done here. You know, $50-some billion a year effect on this country, and why we've left it behind for so long, and the relationship that neurologists never had with ED physicians, because in the early 90s, you know, there was a lot of infighting, we'll call it, between neurologists and ED physicians. So I commend all of you folks for your work that you're doing on stroke care and helping to bring ED physicians and neurologists into the same room. We know it's worked for STEMI, I mean, bringing cardiologists and ED doctors together, and these teams are really doing great work.